Welcome to the Brain and Behavior Research Foundation's Meet the Scientist monthly webinar series. I'm Dr. Jeff Borenstein, BBRF's President and CEO. Today, Dr. Adriana Feder will present developing a potential new treatment for chronic PTSD, ketamine combined with written exposure therapy. BBRF is the world's largest private funder of mental health research grants supporting transformative discoveries in order to develop improved treatments, cures, and methods of prevention. The high quality of the research we fund is made possible by the BBRF Scientific Council. This group of over 190 prominent mental health researchers reviews each grant application and selects the most promising ideas with the greatest potential to lead to breakthroughs. The Scientific Council guides the foundation to fund creative and impactful basic, translational, and clinical research relevant to the whole spectrum of mental health. One reason that research funded by BBRF has had such great impact is that we do not limit our focus to one illness or condition. Since 1987, the foundation has awarded $462 million to fund more than 6,700 research grants around the world across a broad spectrum of conditions, including addiction, ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, eating disorders, OCD, post-traumatic stress, schizophrenia, as well as suicide prevention. Today, I'm delighted to introduce Dr. Adriana Feder. Dr. Feder is professor of psychiatry at the Icahn School of Medicine at Mount Sinai. She was a 2015 BBRF independent investigator and a 2002 BBRF young investigator. Our webinar will begin with Dr. Feder's presentation, which will then be followed by Q&A. To submit your questions, please use the Questions tab on the control panel. Feel free to submit your questions at any time during the presentation. I'll ask as many questions as time allots at the end of the formal presentation. And now I'm pleased to introduce Dr. Feder. Adriana, the floor is yours.
Hello, everyone, and thank you, Jeff and the BBRF, for inviting me to present. Can you hear me okay?
Yes, we can.
Okay, great, thank you. So I'm going to, let me just change this to see. Okay. All right, so yes, as Jeff mentioned, I'm going to present what led up to and including this potential new treatment, combination treatment, and I will start by talking a little bit about, historically how we developed ketamine, how we started studying ketamine for PTSD, and how we ended up adding psychotherapy, the combination. Okay, so this is my disclosure. So ketamine, as many of you know, is an NMDA glutamate receptor antagonist. And historically, first intravenous administration of ketamine was shown to have a rapid antidepressant effect in individuals with treatment-resistant depression, often seen even within a few hours, but very much observed after one infusion at 24 hours. What is known from several studies, many studies following after that, is that repeated infusions are necessary of ketamine in order to maintain improvement in depression, and as we will see in PTSD as well. And then, as you, many of you know, the S enantiomer, just briefly, molecules are either of a medication are either right-handed or left-handed, usually a combination of both. But S-ketamine was developed under the name Spravato, and that's the S, the left-handed molecule. And several years ago, it was approved by the FDA for intranasal administration, added to an oral antidepressant for patients with treatment-resistant depression, and more recently for patients with depression with acute suicidal ideation or behavior. So now, when we did the first study of ketamine for chronic PTSD, it was funded by the Department of Defense, and the principal investigator was my mentor, Dennis Charney, and I led the study working with him. And this was the first proof. And when we conducted this study, ketamine had started to be shown to be effective as administered IV at sub-anesthetic doses, lower than those required for anesthesia, in patients with treatment-resistant depression. So evidence had started to come up about that, and we decided to try it in PTSD. I do want to say that, as many of you know, ketamine has been available for several decades and used as an anesthetic medication to put patients to sleep for procedures, and it is FDA approved, was approved as an anesthetic medication, and it has been used for decades for anesthesia in children as well. So we conducted the first proof of concept randomized controlled trial, and it was 41 patients with chronic PTSD, at least high, moderate to severe PTSD. The majority were civilians, about half of them were men. And we showed a robust reduction in PTSD symptoms and comorbid depressive symptoms. And the improvement in PTSD could not just be explained by the improvement in comorbid depressive symptoms or associated depressive symptoms, because it also helped a lot with things like hypervigilance, intrusive thoughts, nightmares, things like that. Now, we observed in that study that the mean time to loss of response, I want to say that was a crossover study. It was one infusion of ketamine, and then every patient 2 weeks later got an infusion of midazolam. In some patients, the first infusion was midazolam, the second one was ketamine. And basically, a subset of patients who got ketamine first, about 7 from the 41 were still improved at 2 weeks, so they did not receive the second infusion, which in that case was midazolam. But on average, the mean time to loss of response in that study was about 48 hours after the single infusion of ketamine. And so we reasoned in PTSD that perhaps we would need to, when we decided to study repeated ketamine infusions for chronic PTSD, that we might have to give a second infusion 2 days later to prevent relapse, since that was the average rate, mean time to loss of response in those who had responded, which were about 2/3 of the sample. So then I was funded, as Jeff mentioned. We were very fortunate to be funded by the Brain Behavior Research Foundation to start the first randomized controlled trial of repeated IV ketamine infusions compared to repeated IV midazolam. And midazolam is different. It's a medication. It's a benzodiazepine, a very short-acting benzodiazepine, like Valium, which is much longer acting. And the reason why our team chose it, starting with the first RCT or randomized controlled trial, and now the second, is because it's considered in this case a psychoactive placebo control. It has the same half-life, approximately 2 to 3 hours. Than IV ketamine, if administered IV midazolam, and it does cause some altered mental function different from ketamine, but the purpose of it was to protect the blind, so that at least some patients, or quite a few patients, would not know if they were getting ketamine or midazolam. This second study I'm going to talk about it in the next slide a little bit in detail. So it was 6 infusions 3 times a week over 2 consecutive weeks. We showed rapid and robust PTSD symptom improvement in the ketamine group. And then I will go on to show more detail in the next slide. And there was also Albert conducted an open label, not randomized controlled trial, clinical trial that repeated with the same frequency IV ketamine infusion in patients who both have treatment-resistant depression and PTSD. These were, I believe, yes, they were veterans, and these were 15 veterans, as open label. And they also showed rapid improvement in PTSD and depressive symptoms. Now, this group had treatment-resistant depression in addition. Ours did not get selected or enter the study because of comorbid treatment-resistant depression. Some of them had comorbid depression, of course. And then lastly, I want to mention more recently, my colleagues, Chadi Abdallah and John Crystal led the study at Yale with a two-site study with a second site in San Antonio with predominantly veterans and a smaller percent of active duty military personnel. And a couple of differences with our study that was also repeated IV ketamine infusions, the second one mentioned here, is that the comparator was saline, not midazolam, and the patients had to have antidepressant-resistant PTSD, meaning that at least they have failed one medication for depression, which is also used for PTSD, for example, an SSRI like paroxetine or sertraline. We didn't have that, so in our repeated study, some patients were taking several medications and were not improved. Some patients had tried several medications, but others had never tried a medication. So that's one difference. And the other is that our study was 77% female, and the study was much larger in veterans, 77% male. And finally, another important difference is that ketamine in the veteran study was administered twice a week over 2 consecutive weeks. So a total of 8 infusions, but they didn't have the 3 times a week more frequent administration that we believed, based on our initial study, might perhaps make a difference in patients with PTSD, unlike those with treatment-resistant depression, where 2 infusions a week compared to 3 times a week were shown not to be significantly different. They both are associated with improvement in a significant, about 2/3 or 60-some% of the sample. In that, so basically in the Abdallah et al. Study in veterans, PTSD symptoms, the primary outcome was the PCL5, PTSD checklist, were significantly reduced over time, but did not differ between treatment groups. But there was a significant antidepressant effect from ketamine. So, lots to talk about that, why the differences. And so I mentioned some of the differences that might account between the study design. So this was our smaller study. We had 30 patients, 15 with chronic high, moderate to severe PTSD. This was the clinician administered PTSD scale for DSM-5. They had to have a score of at least 30. So 30 is a few points, several points into moderate, so high moderate PTSD. As I said, predominantly female, and the mean PTSD duration was 15 years. Here you can see they would get half and half, 15 and 15, randomized to ketamine midazolam, and they received, let's say, one typical schedule was Monday, Wednesday, Friday, Monday, Wednesday, Friday, 2 consecutive weeks. And by the following Monday, with some variation for scheduling, was the primary outcome. So the primary outcome was a change in CAPS from baseline before any infusions to the 2 weeks following the first infusion. And we actually, only those who were considered responders, or in this study, at least 30% improved, following some other studies in PTSD that considered at least 30% response. They were followed for several months or until relapse. And this study was published in 2021. These are some quotes from patients after receiving repeated infusions, some of them earlier, some of them later, after a couple of infusions. I don't feel my life is going to end anymore. It made it impossible to plan a future. I want a life now too. This was someone who had been sexually assaulted as her primary trauma. And after interacting more recently during the study with someone who had been harassing her at work, one huge thing I'd noticed that's different. Before I would have panicked. He's been very aggressive. I don't feel panicky or afraid. This one, the second one, was had a history of childhood trauma in growing up, also into adolescence. And after repeated infusions, she said, I feel like a normal person. I seem like a normal person. My brain doesn't let me in. This was someone who chronically experienced suicidal, passive suicidal ideation. Now, when she thinks about the past trauma, it doesn't make me feel way down. I have to dig out the memory as if from an attic. Before talking about it, used to make me feel a terrible feeling. And lastly, another trauma survivor, feeling like I have the energy and want to do things again. I feel like I made peace. I could go past it. I could let it go. It's been a gradual acceptance. I haven't felt this safe in a long time. So this is what we saw with repeated ketamine alone. Those are some of the quotes. These are the Monday, Wednesday, Friday, and the second week, Monday, Wednesday, Friday. And so the primary outcome was changed from here to here. And you see a drop of almost, well, let's say 18 point something. I think it was 18 point, a little over 18 points in the CAPS, which is a lot, from before the first infusion to the Monday after the course of 6 infusions. And you can see that the improvement, and the blue one is midazolam. Can you see my cursor?
Yes, we can. We can. It's
you
visible.
Can. Perfect. Great. So you can see that pretty much throughout the 4 DSM-5 symptom clusters: intrusion, avoidance, negative alterations in cognitions and mood, and arousal and reactivity, that there's improvement throughout. And the only one that was almost, well, it was a trend, not significant, of these clusters was arousal and reactivity, which includes things like sleep and concentration. And this could be because midazolam is a hard comparator, because it is also anti-anxiety, and it's not expected to last, until, after it's cleared out of the system over the course of, let's say, about 15 or 18 hours, since the half-life is 2 to 3 hours. But it might have, for example, the following day, after the same night after the infusion, those patients might have slept better, for example, because they did have a medication for anxiety. So that might be why this difference is a little bit less. And here you can see that in the ketamine group, 2/3, in the ketamine group, 2/3 were considered responders, 67%, compared to only 20% who were considered responders in the midazolam group. And that's why it's important to do a randomized controlled trial, because even some people in the midazolam, the comparison group, can have a response. But it was significantly better in the ketamine group. Now, one thing that, same as in studies in individuals with treatment-resistant depression, these are here, we have the 3 people who were responders to ketamine and the 10 people of the 15, the 3 people who were responders to midazolam, the blue. Time 0 is the primary outcome, the 2 weeks after all the infusions. So the Monday after the 6 infusions. And the red line is the ketamine. And so there were 10 ketamine responders of the 15 participants who were randomized to ketamine, and there were 3 midazolam responders. And so we see the ketamine that over time, the majority will lose their response. And among ketamine responders, median time to relapse or loss of this response would be more accurate, was about 4 weeks from the primary outcome day, or about 6 weeks from the first infusion. So this is a problem, and this can be potentially solved, though it hasn't been studied in PTSD, by continuing to administer ketamine infusions over time, the way ketamine clinics will do it naturalistically, even though it's off-label, or the way esketamine was intranasal Spravato or esketamine was developed for the treatment of treatment-resistant depression, where the intranasal administration can be continued over time. Now, I'm going to pivot to the idea of adding a trauma-focused psychotherapy. So what is the mechanism of action, potential mechanism of action, so of ketamine? So this is an animal very well known from now way over a decade ago, of chronic stress. And so what these investigators showed, Lee and their group, in an animal model of chronic stress, where animals subjected to 21 days of chronic uncontrollable stress show an atrophy of the numbers of the dendrites and the numbers of dendritic spines, so the connectors between the neurons, the dendrites, of these important layer 5 pyramidal neurons in the cortex of the brain. And they showed that after a single dose of ketamine administration, in this case, I believe it was intraperitoneal instead of intravenous, they showed a rapid, so 24 hours later, a rapid reversal. You can see there's a lot of growth of dendrites and dendritic spines in this case. And so the mechanism that are understood, but they're not fully understood, is that this type of NMDA receptor antagonist, ketamine, stimulates AMPA receptors by blocking the NMDA receptor, and some intracellular messengers, pathways gets activated, and this increases protein synthesis, that proteins that are essential for forming synapses and for maturing synapses. So this chronic atrophy of synapses gets reversed acutely in 24 hours. So it is thought to peak this effect based on the animal studies 24 hours after ketamine administration. And that's the basis from some studies of how others have tried to combine ketamine with psychotherapy that I'll go into. And John Crystal at Yale has written about, based in humans, what we can see is reversal of abnormal connectivity patterns, using MRI in depressed individuals, and as I will show in PTSD as well. And he called, John Crystal labeled PTSD based on this as synaptic disconnection syndrome. So it could be that, so obviously neurons and brain regions are connected by synapses. And if in the animals we see synaptic loss following chronic stress and also PTSD, it's possible that in humans, that's why we're seeing disconnectivity between brain regions that are important for emotion regulation. So now we know that trauma-focused psychotherapies are based on studies, are thought to rely on adequate threat processing and also fear extinction and emotion regulation. So there have been several now studies, published studies, neuroimaging studies of trauma-focused psychotherapy, typically exposure-based. In this presentation, I'm basically calling trauma-focused psychotherapies and exposure-based psychotherapies. I'm treating those as synonymous. And these findings, so in fMRI studies before exposure-type therapy and after, suggest that if the poor top-down inhibition by the frontal cortex of the amygdala being the sort of lower emotional brain, activates in response to emotions or including fear, happy stimulus, and when the amygdala activates too much, either because of amygdala or overactivity or related difficulties or a problem with inhibition, the prefrontal cortex, the frontal cortex, higher up centers of the brain, do not inhibit the amygdala sufficiently. So some people with PTSD in particular, can have overactivation and excessive fear of the amygdala, sort of simplified explanation. And so those who had too little inhibition, or the amygdala activated too much, the prefrontal cortex too little, before starting a prolonged exposure therapy or exposure-based psychotherapy, those are the ones that have a sort of a less well-functioning emotion regulation and possibly extinction learning circuitry in the brain, have poorer response. Whereas, so response to these therapies, they're the most effective trauma-focused psychotherapies, exposure-based psychotherapies. So a lot of interest, can be even more effective, are known to be more effective than typical medications like SSRIs for PTSD. However, there are high rates of dropouts, sometimes a third, or about up to 40%, sometimes over 40%. Patients drop out because they're difficult to tolerate. It may be that those patients who have more severe, more difficulty inhibiting the amygdala in their brains are more likely to drop out, or it might be less effective for those patients. And we know from studies in PTSD that a substantial proportion of patients with chronic PTSD do have impaired function in these circuits associated with emotion regulation, threat learning, and extinction, which are thought to underlie the workings of exposure psychotherapies. So there's been wide interest for quite some time now in investigating combination of ketamine and trauma-focused psychotherapy for PTSD. And my colleague at Yale, Ilan Harpas-Rutem, has had this interest for a long time, and I'll just briefly mention these findings. And then Paolo Shiroma as well. They conducted the first 2 studies, which I'll go into in a moment. We also know from basic animal studies that early on, Girgenti and Duman showed, and there was, because of the interest in ketamine and how it helps potentially in PTSD or stress, animal studies were done, and Girgenti and Duman showed that ketamine can accelerate fear extinction via this particular pathway, mTOR signaling intracellular. Now, not all studies have shown this, but this was an important study that showed that. And then another study by Sala and Musazzi showed that acute ketamine administration facilitates fear memory extinction in a rat model of PTSD. So they developed what could look like PTSD in rats based on exposure to stressor, foot shocks, and along with restoring, it enhanced fear memory extinction, and it restored, reversed the atrophy in the dendrites that I was mentioning, the prefrontal cortex. So before it was ketamine alone, here is the pairing of fear memory extinction in animals together with ketamine. And then Paredes and Morlack showed, a different group, that adjunct treatment with ketamine enhances the therapeutic effects of extinction learning, also in a preclinical model, this time in rodents subjected to chronic unpredictable stress. Administering ketamine also enhanced. It made the extinction learning, or extinction of the fear, it was enhanced by ketamine. So this is very hopeful. Now, these were 10 and 10 participants. So I had shown you our study here. So there were 15 here and 15 here that were randomized to ketamine and midazolam. And 10 of these, so 2/3 in each group, were able to also participate in a brain imaging study that was done. So they had a baseline fMRI done before any infusions, and they had a follow-up, a second MRI, after at least 4 infusions, some of them 5, some of them 6. We didn't do them all at 6 because we had so many other assessments at the primary outcome. And so many participants had it after 4 infusions, but still repeated infusions. So what we saw, and these analyses were conducted by my then postdoc, neuroscientist, computational scientist, Dr. Agnes Norbury, who's fantastic, and she's gone on to do some wonderful other studies in the UK. She found an interaction between, so we showed them fearful faces or neutral faces or sad faces, and there was an increase in connectivity between the ventromedial prefrontal cortex and the amygdala that was more pronounced in the ketamine group than in the midazolam group. And this increase was correlated after adjusting for multiple other variables with improvement in the total PTSD symptoms. So those who were more improved had more of a change, or it was fixed, improvement in this top down. And I'll show that preliminary find. This is all preliminary because it was only 10 and 10. It was published in Neuropsychopharmacology journal. And she also showed that at baseline, it was those who had worse ventromedial, this is not shown here, but those who had lower ventromedial PFC to amygdala connectivity at baseline were more likely actually to respond to repeated ketamine. So kind of different methods, different studies, but different, a little bit perhaps the opposite, that imaging studies at baseline before exposure-based psychotherapies or trauma-focused therapies, those who have a well enough functioning brain and ventromedial PFC to amygdala connectivity might seem to be the ones who respond better. Whereas here, it's those who have the worst connectivity at baseline, the more maybe synaptic atrophy, reduced connectivity in these crucial regions, important for fear of extinction and for emotional regulation. Those who are doing worse are the ones who respond better. And so there were other things with this other task where there was either a congruent condition where the participants saw a fearful face with the word fear, an incongruent condition where they saw a fearful face but it said happy, and they had to ignore the words and click or pay attention to the emotional expression in the face. There was a change in the dorsal anterior cingulate cortex, which is a region that also responds to emotional and including fearful stimuli together with the amygdala during this emotional conflict situation, happy with a background fear. So improvement in the more improvement, lower improvement was associated with higher change in the dorsal ACC. And we also saw some changes in the ventromedial PFC and the anterior insula, a difference between the ketamine and the midazolam with resting state connectivity. This is not what I wanted to focus on, so I'm going a little quickly here. And here, Agnes Norbury did some additional exploratory analyses looking at the directionality, actually. And in both groups, as I had shown before, there was this association, change, reduction in basically greater symptom improvement and lower face-related excitation of the ventromedial PFC by the amygdala, but only in the ketamine group. Improvement in PTSD symptoms was directly associated after adjusting for other covariates with more top-down inhibition. So you can see this in both, but this one, the top-down, there was a difference in the ketamine group, more control of the lower emotional brain by the ventromedial frontal cortex in the ketamine group after treatment than in the midazolam group. And that was associated with PTSD symptom improvement. So it's only evidence, this pattern of increased top-down regulation, preliminary findings in 10 and 10 participants, is only seen in the ketamine group, the association between this pattern and PTSD symptom improvement. So what does this tell us? PTSD symptom improvement after repeated dose ketamine seems to specifically involve greater top-down inhibition, as we said, of the amygdala by the frontal cortex, ventromedial PFC. And this has, and in response to emotional stimuli, in this case, faces. And this has intriguing parallels to neural mechanisms that have been implicated in successful extinction learning, including by my colleague here at Sinai, Daniela Schiller, and by Mohammed Malad. And so, and again, as a reminder, extinction learning, successful extinction learning of the fear, of the memory, of the trauma, is thought to be crucial in exposure-based psychotherapy. So this was the rationale for pairing ketamine and a trauma-focused psychotherapy. Could there be a potential synergism? So we talked about abnormalities in fear responses, emotion regulation in many patients with chronic PTSD, most patients or many, and this has been attributed to synaptic disconnection and dysregulation of the amygdala reactivity to threatening stimuli in the environment. We administer ketamine. Ketamine temporarily, we saw it was temporary because after several weeks, we saw it in the clinical. We didn't conduct a MRI study showing that the changes revert back, but we did see clinically most patients with chronic PTSD relapse after, several weeks after the first infusion, when given 6 infusions over 2 weeks. So ketamine increases temporarily neuroplasticity in the brain, and it seems, based on preliminary imaging study, which was the first neuroimaging study of in PTSD, of ketamine for PTSD, by increasing top-down inhibition of the ventromedial prefrontal cortex of the amygdala. This is something else that I'm not going to get into in this presentation. And then during this period of increased neuroplasticity, there's an opportunity to deliver, especially a brief, we selected, and I'll talk about it, a brief trauma-focused psychotherapy, written exposure therapy. And because it's more scalable, and if you already have a better functioning brain, even more reason to add a brief psychotherapy that has been shown, as I will show next, to be non-inferior to more extensive or traditional first developed prolonged exposure and cognitive processing therapy. And so what we're interested in is to find out if ketamine may enhance the efficacy of written exposure therapy in individuals with chronic PTSD. Very briefly, I'm not going to go into the details, but Paulo Shiroma also conducted and published in 2020 an open label study consisting of traditional prolonged exposure in veterans PTSD, 10 of them. They received 10 weeks of once a week prolonged exposure therapy and 24 hours before the first 3 sessions. So over the first 3 weeks, 24 hours before the first 3 sessions of PE, they received a ketamine infusion at the typical subanesthetic dose, 0.5 milligrams per kilogram. And 5 participants completed the full treatment. 5 others did not complete the full PE. They completed anywhere between 3 and 8 sessions, half of them. And the other half completed the 10 sessions. And they showed that the CAP scores decreased significantly from the baseline to the end of treatment after 10 weeks. And then my colleague at Yale, Ilan Harpas-Rotem, who also he conducted the first randomized controlled trial of a single infusion of intravenous ketamine compared to a single infusion of intravenous midazolam. And this study was funded by an independent investigator award from the Brain Behavior Research Foundation as well. And this was the only randomized controlled trial, but it included only 1 ketamine infusion versus 1 midazolam. And what they did was a bit different, is participants were in the scanner, they listened to a trauma script based on their own personal trauma in the scanner. Then they receive an infusion. So the infusion was given after the reactivation of the memory. And then 24 hours later, after the infusion, and again, you see this 24-hour concept because that's when in animals it is thought to peak the effect of on the brain of ketamine, a single infusion or administration. all patients received a 4-day back-to-back trauma-focused psychotherapy, which is prolonged exposure but modified, shortened, but very intensive. And they actually, everybody, after 1 infusion of ketamine versus 1 infusion of midazolam, everybody received 4 sessions back-to-back of prolonged exposure modified. And they found clinically no significant difference between the ketamine and midazolam group, because both groups improved significantly. But, and I'll let you look up their papers for more details, but they did find changes in neural function. They did an MRI at baseline. They did one, I believe, at, let me see. Yeah, day 7, and then 30-day follow-up, and even a 90-day follow-up. So they did find some changes in the ketamine group having to do with lower, for example, lower amygdala reactivity, and changes in the density of the white matter in the onset of fasciculus, which is important for emotion regulation, part of the limbic system, and that related to PTSD symptom improvement. This one in the group in everybody who improved as a whole, there were these changes, and there were potentially there was a larger reduction potentially in neuroactivity associated with trauma memory in the ketamine group than the midazolam. But as I said, clinically, and this was, in this smaller, 27 reasonable sample, because everybody responded, a substantial proportion of patients in both groups responded to the intervention. They did not see a difference clinically. Okay, so this is our study. So our study is an open label clinical trial. So that's important because it's not a randomized controlled trial. A lot more needs to be done. But I'm going to walk you through our methods and the rationale for our methods and our initial findings from this open label. So everybody knew they were getting ketamine and they were getting the exposure therapy. So Denise Sloan, one of the 2 developers of this novel and very, very effective written exposure therapy, Brian Marks. Denise Sloan was a close collaborator with my team and with me throughout this study, and she trained the therapists who administered the written exposure therapy intervention. And I came across this therapy a number of years ago, and I was very intrigued because at the time it had shown to be non-inferior to one of the 2 gold standard therapies for PTSD called, as you might, of course, many of you know this therapy, cognitive processing therapy. And so it typically takes 12 weeks, this cognitive processing therapy, whereas in this study published in JAMA Psychiatry in 2018, they administer written exposure therapy once a week for 5 weeks. So by this time, you can see those who got wet or written exposure therapy, the orange group, had received their 5 sessions. And you can see that there's no significant difference between the 2 groups. And so I will show it starts, the written exposure therapy, patients write for 30 minutes, and it's facilitated by a therapist who is either in the room with them or on a video call with the patient. And the patients for 30 minutes over 5 sessions, they write repeatedly about the trauma linked to their symptoms, and with particular attention to felt emotions. And later on, the last couple of sessions, transitioning, still writing about emotions, but also transitioning also to the meaning of the traumatic event and the impact on their life. So to date, Denise Sloan and collaborators have actually now completed 3 randomized controlled trials, 2 of them showing non-inferiority in veterans and a predominantly civilian sample, non-inferior to cognitive processing therapy. This first one is the one from this graph here. And more recently, also was what was shown to be non-inferior to prolonged exposure, the classical one that was also shown to the gold standard form of therapy for PTSD. I do want to say that this was the case with significantly lower dropouts. For example, in this one, the dropout was less than 10%, I believe 6% in the wet, and in CPT, it had over 30%, I believe, dropout. So as I had mentioned before, these traditional therapies are very effective, but about 50% of patients do not respond sufficiently, or they might drop out early, not tolerate these types of therapy. Wet is associated with lower dropout and similar rates of response to the and shorter time of administration. It requires much less training of the therapist. So these are the instructions, and there's a lot more instructions, and the therapist will read from the instructions. So write about your trauma from the beginning, smell, heard, sensations, feelings, as you remember it now. That's one difference compared to prolonged exposure. Session 2, trauma, continue where you left off. Again, what you saw, heard, as vividly as you can, thoughts, feelings, and then the patient writes for 30 minutes. The first session lasts for an hour because there's about a 20-minute psychoeducation about why exposing yourself and writing about trauma might be beneficial. And the other ones last about 40 minutes, and 10-minute interaction with the therapist and the writing. And the key role of the therapist in between the sessions is what I also learned by being involved in this, is that the therapist will read, the patient provides the therapist what they wrote during the first session. The therapist will read it in between sessions, and we'll see, for example, was the patient really immersing him or herself into writing about the trauma, or are they avoiding writing about what led up to the trauma and then quickly going to what happened after the trauma. And so here, in the second session, the therapist will go back and say, good effort. I want you to now try to go back and to the most traumatic part and really try to stay with the trauma. Here is the worst part. Actually, the worst part comes here, and then starting to write about how it affected and changed your life, the meaning of life. Again, worst trauma and impact on the meaning, and then more exposure, and then how trauma changed your life. I do want to say that what I've learned from Denise and my therapist being the therapist in the study being supervised, is that you can also be a little creative. And so, for example, in one patient that had a major trauma where a close friend passed away in a big accident, she had a lot of survivor guilt that was maintaining this the PTSD symptoms, and so Denise recommended that the therapist ask the patient in this last session to write a letter to her deceased friends, which she did, and she felt, based on what she told us, her experience, that a weight really lifted, that she was able, it was very cathartic. So, and this is something that is done in grief work. So in general, there's some deviations, or if in the first 3-4 sessions, in the first 2 sessions, the patient doesn't really expose themselves and they're still avoiding, then, another thing that I learned from Denise, and you can actually prolong and devote more time to because the most important part is the ability to write about the trauma and face the trauma head on in the writings. And so you can actually devote more of the time in these sessions to writing about the trauma vividly, emotions, sensations, and less so focusing on the meaning of life. So this was our design. And so here, we actually have a grant currently under review where we're actually going to do this a little bit differently, but this is the typical Monday, Wednesday, Friday, Monday, Wednesday, Friday. So same frequency, the way we did this study as in our first randomized controlled, when we did the randomized controlled trial, repeated ketamine. And then the Tuesday after the fourth infusion, we did an assessment and we used the CAPS, the gold standard clinician administered PTSD scale, as the primary outcome. Participants received the first session of WET. And then they got the 5th infusion the next day. Then the next day they got the WET, and the next day. And so here, because we know that, really after a participant gets with PTSD, a patient with PTSD gets several infusions, if their brain is going to improve, not everybody improves, but the brain is going to respond, it's going to last longer. We showed, last for a few weeks. Remember, the median time to loss of response was about 4 weeks after here. Although some people started relapsing like 2.5 weeks after here, so 4.5 weeks. So we knew, so this was an extra thing to kind of interleave. We did not administer the written exposure. This is very different from ketamine-assisted psychotherapy, where, which, there's potential issues. There's studies in healthy humans where aversive memory and also appetitive memory of some food was brought up during ketamine infusion, and their memories were cemented, were made more, the aversive memory was like not something, that would harm them. But because we know that if you bring up a bad memory, a traumatic memory during the infusion, it's possible it could be made worse, stay more entrenched. And so that's why we made sure not to do it on the same day. For the proposed trial, which is a larger randomized controlled trial with colleagues at other centers, we actually are going to separate the infusion times and start wet, so week 1 and 2, and start wet week 3 and administer week 3 and 4. Just so that you can separate both, and we can do a brain imaging here after the infusions, and then after wet, after the combined treatment, which is to say if we are funded, which is a tall order because it's a very large study. So anyways, one thing I want to mention is that Denise Sloan and colleagues have done many studies now of wet, and they will administer it daily for 5 days consecutively, once a week. So here we did 2 of them 1 week and the other 3 the second week. So it was more condensed, but it has been condensed even more. Our primary outcome, because as you remember, we wanted to see the duration of this, and also we, one of the main outcomes in the wet alone historical studies was at week 12. Week 12 is the first 12 weeks after start of wet. And then there's an additional 10 days between baseline and week 0. And then those who were responders, at least 30% better here, we follow them up to week 24. So for about, this is 3 months from baseline, week 24 would be 6 months approximately from baseline. So briefly, 14 patients were started ketamine. 1 participant we had to withdraw, decided because of inappropriate behavior with study staff, and that left 13 participants, and the 13, so this was unrelated to the infusions. This participant received 3 infusions of ketamine, did not start wet, was withdrawn, and then the 13 remainder participants that started the treatment completed all 6 infusions, all 5 wet sessions. And so these 13 were analyzed. Just a brief overview of the demographics. Mean age, 38, duration of PTSD, 18 years. The caps, you remember that a 30 was a few points into the moderate range, 37 is severe. So on average, very severe PTSD. A subset of them, you can see the MADRS as for depression. You can see that like patients, most patients with severe PTSD will have comorbid depression. So also meet criteria for major depression. So here, 10 of the 13 did. There were highly educated group. And you can see other comorbid, more severe PTSD it's common for it to be presenting with other conditions, anxiety disorders like generalized anxiety, social anxiety. 7 of the 13 were, they were not allowed to be, we didn't take participants who were engaged in exposure-based or evidence-based psychotherapies, like prolonged exposure, EMDR, but they could have supported therapy. Some of them were seeing a therapist once a week, and for supportive therapy, 7 of them, or less or more frequently. 6 of them, a bit less than half, were currently on 1 or more psychotropic medications. So for example, an SSRI, and they might have been on prazosin, and they might have been on something for sleep, and perhaps, some people were taking another antidepressant like mirtazapine. And then marijuana was allowed it was discouraged, but we didn't take anybody who was using it regularly. But one patient used it on the weekends only, and during the treatment phase. And we didn't want patients to be using marijuana to dampen the effects of the written exposure therapy and sort of check out shortly after wet. So we allowed it on the weekends in this case, or they had to wait several hours before using marijuana. And so these are the primary findings of our open label. I'm going to go pretty quickly to leave time for a couple of questions. So there was a big drop in the caps. And remember, this is at 12 weeks. So this was comparable to what we saw at 2 weeks with repeated ketamine alone. A drop in about a bit bigger, but about similar. And it was significant across all the 4 symptom clusters. Also improvement in depression. 77% felt at least much improved or very much improved. And so briefly, as I mentioned, one participant was withdrawn early. All other participants, no dropouts. Just like in previous studies, any acute dissociative symptoms during infusions were transient and resolved after the end. And these were some of the side effects on infusion dates, more frequently, consistent with other studies of ketamine. I'll show this. A few patients experienced a little bit of a slowdown in PTSD symptom improvement following the first couple of wet sessions. And this is expected because they're writing about trauma, and some of them, but most continue to improve, who are going to improve. And one patient who was a ketamine responder, responded very nicely to the first several infusions, had a lot of difficulty tolerating wet and started getting worse during wet sessions, and was one of the 4 non-responders at the 12 weeks to the combined treatment. This patient had a particularly severe, interestingly, early life trauma throughout development, childhood, and then multiple sexual assaults throughout adolescence by 2 close members of close member of her family and a friend, so of the family members. So this one has a particularly severe trauma throughout development, and for whatever reasons, we can't say that's why. She had a lot of difficulty. We told her she could discontinue WEP, and she said she wanted to finish it. This is overall. So these are the first 4 infusions and the last 2 infusions, and then there's the first and last wet session. So the whole treatment was about 3 weeks long, where the first and second week, they received the 6 infusions, and the second and third week, they received the 5 wet sessions. And this is weeks from start of wet. So this one is called baseline, and right before the first wet session is called 0 week. And similar response across all symptoms. And then at week, one thing that was interesting is that those who responded, who were going to be responders at 12 weeks, they responded early. If they were not better by week 3, at least 30% better, they were not going to be in the responder group. Only one of the 4 who were not responders at week 12 was better by week 3. So we have 77% that did not have PTSD by week 12. Sorry, by week 3. By week 12, we have almost 70% responders, and more than half did not meet criteria for PTSD. And then at the 24 weeks, here we followed only the responders at 12 weeks, more than half, plus 1 participant. So almost 60%. Last participant was last evaluated at week 20, about 6 months from baseline. About 60% were still better, which is very different from, and these are the individual trajectories. This paper was just published last week, so you'll be able to access it online in the Journal of Clinical Psychiatry. The blue ones are those who responded, and the black ones are the ones who did not respond. This one responded to ketamine, but then relapsed. And then here you can see when they start wet, some people get a little bit uptick in or flattening of their response, and then they continue to get better way after the combination. So very briefly, I know I'm out of time. Just wanted to emphasize that IV currently is off-label. not FDA approved for any psychiatric disorder when administered IV, and the only S-ketamine FDA approved for depression. We talked about the window of increased neuroplasticity. If we administer several infusions prior to starting wet, the idea is to prime the brain. And then we talked about this already, and it was feasible. It was an open label. It was safe. We demonstrated preliminary efficacy, rapid response, large magnitude improvement. The treatment response was maintained at about 60% at 6 months. And the effect of the combined treatment is similar, comparable at 3 months to the standalone ketamine treatment at 2 weeks. And we need randomized controlled trials to see if it's larger than only wet at 3 months. And wet seems to perhaps prolong or maintain the improvement. So maybe this would avoid or reduce the need for maintenance infusions. Larger randomized controlled trials are needed, and then future neuroimaging, mechanistic neuroimaging studies. And I want to thank the very large team, especially Dr. James Murrow, the director of the Depression and Anxiety Center, where we conducted the study, coordinators Onisha Brown, Sarah Rudder, Leah Kahn, therapist for most of the participants, Agnes Norbury, and neuroimaging analysis, Dean Dennis Charney, with whom I started ketamine studies for PTSD, Jessica Overby and Robert Peterzak for their statistical expertise, and foremost, Denise Sloan for making the study possible and designing WET, and then helping us with the study, and really thankful for Brain and Behavior Research Foundation for their support, and Mount Sinai Individual Partners, and donations from the Greenwald and Aaron Krantz families. Thank you.
Thank you. Adriana, thank you for, yes, thank you for an excellent presentation, a lot of information. We don't have time for questions, but you really covered a lot in there, including future directions, which is something I would always ask people. So thank you for your presentation and for the work that you're doing.
Thank you very much. And if anyone would like to email me a question afterwards, adriana.feder@mssm.edu, I would be happy to connect.
Wonderful, wonderful. Thank you. So in addition to thanking Dr. Feder, I also want to thank people for joining us today. And I'd ask people to consider making a donation to BBRF. 100% of every dollar donated for research is invested in our research grants. We're able to do this because our operating expenses are covered by separate foundation grants. This means that if you donate $1 for research, that dollar goes to the researcher. Please contact us by going to our website or calling us at 1-800-829-8289. The webinar has been recorded. If you've missed any portion or would like to share it with family or friends, you can do so from our events and webinars page on our website. And I'd like to ask people to join us again on May 13th at 2 p.m. Eastern Time, when Dr. Kristen Javaris of McLean Hospital and Harvard Medical School will present "Is Stress Really Desserts Spelled Backwards? How More Objective Assessment of Eating Behavior Can Refine Our Understanding of Stress Eating." Thank you, everybody, for joining us. And remember, together, we can dramatically improve the lives of those living with mental illness and enable more people to live full, happy, and productive lives. Take care.